Hello everybody, welcome to Talking Tendons podcast. This episode I had a really interesting chat with Shawn Hanlon, who is a PhD candidate in the Karen Silbernagel lab in Delaware in the US, and he's recently published an interesting paper looking at the concept of different characteristics that cluster together among people with Achilles tendinopathy. So trying to uncover some of the heterogeneous presentations that we see, which has been interesting to read and learn more about. And this podcast has lots of really good clinical info in relation to that. Hope you enjoy it. All right. Welcome, Shawn, to Talking Tendons podcast. How are you?
Doing very well. Thank you so much for having me.
No worries. Thanks for coming on. So basically, just to start off with, tell us a bit of background about yourself. What are you up to at the moment? Where are you working? What sort of things are you doing?
I'm sure. So I'm a certified athletic trainer, strength and conditioning coach. Been for about 10 years. And then prior to starting the PhD, I worked in the collegiate athletic setting. I was the director of sports medicine at a local university for a number of years. And I kind of fell into tendinopathy by chance. The Achilles and patellar tendinopathy started to really plague every one of my teams, season to season. And so I started to look into the literature a lot more than what I had learned in my education. And then luckily at the time, the 2015 or 2016 maybe, tendinopathy special in JOSPT came out, and that changed everything for me. So just coincidentally, I was signed on to do a local speaking event on Achilles tendinopathy, and it turned out Dr. Silbernagel was going to be there as well, speaking on the same subject. So I went to her and I said, I had all these questions on how I can manage my athletes and why I'm struggling so much to get people to stay recovered. And her response to me is, well, these are great questions. You should come do a PhD and we'll answer them together.
Yeah.
And so the rest is history. That kind of led me into where I'm at. First, recognizing with her, this is not just a symptom problem and a function problem, but there's a lot more to the complexity of Achilles tendinopathy than just what meets the eye and what you can get out of a simple conversation with your patient. So I started to kind of come up with this realization, all right, I get that exercise therapy has the highest level of evidence. It seems to be a very effective treatment, but why isn't it getting everyone better if it's the best we have? And why aren't, what's happening to this subset of people? Why aren't they responding? And it really made me change my focus to, or why focus on the people that are doing well? Let's turn our attention to those who don't make the grade, who are having recurrent symptoms, who aren't responding to our best intervention. And I stumbled upon a paper that started looking at a completely different topic, but started to recognize that you can predict trajectories in recovery following people over time, and start to make predictions on how they might respond to a treatment based on their characteristics and their baseline qualities. And so met with our local biostatistician, our university biostatistician, Dr. Pohlig, and I was trying to shape this terrible worded idea, scribbled on a page to him, and he smiled and said, well, actually, there's a very rigorous statistical analysis that we can do to answer this question. It's going to take a year out of your life and you're going to go very deep down this hole. But if you're willing, it's going to really set you up to answer a lot of these questions. And so that was it. I said yes to that. And the next thing you know, we were identifying that there are subgroups within the general population of Achilles tendinopathy. And we all kind of sat back together, Karin and I and Ryan went, we see these patients every single day. This isn't new information, but we've never really seen it on paper and been able to actually pinpoint how we can categorize a patient based on the domains of tendon health that we're constantly, talking about and discussing. These are the things that we should be appraising in a patient. They seem to have actual clinical utility.
Fantastic, and we're gonna go into that paper. We'll talk about it more, but I think that's a really good story about how, with research, you sort of have to have a really good idea and then be having the courage to pursue it and really go after it. And that's really good. And it doesn't always lead to a really good outcome at the end, but in your case, there's some good findings which we'll talk about. So that's great. So you effectively started working with Karen and have been at the lab there for a few years now?
Yeah, I joined in 2018.
Yep.
And we had met about a year prior, and I was aware of the R01 project that she was hoping to start, and she had kept me in the loop the entire time and basically said that when this funding comes, I will call you. And I had a great job. I was very happy where I was. When I decided then and there that the PhD is where I want to go. So the same day that she called me and said, the project is funded, I'm going to need someone to help me carry out all of the data collections. I called my boss and said, all right, this is it. The new opportunity is here.
Excellent. That's really, really good. And you're there as a PhD student at the moment. And one of the reasons I really wanted to talk to you was to really get a bit of a deep dive into your paper, because I think it has been a really nice and interesting one to read. And that is Beyond the Diagnosis, Using Patient Characteristics and Domains of Tendon Health to Identify Latent Subgroups of Achilles tendinopathy. I'll link it to the Talking Tendons podcast, so people please read it if you haven't read it. It's a really interesting paper, but I think we'll probably talk about that in a bit more detail. I'll also link the tendon JOSPT series 2015 that you mentioned, because I agree that was a really, really good series of tendon papers there as well. So let's get into your study. Just tell us a little bit about, you've already said the motivation was to try and understand why people maybe, or sort of try to understand different groups in Achilles tendinopathy and try and sort of move into that more so. Was it from a perspective of, as you say, patients just weren't getting better, or just thinking, how can we, were you thinking at that point, were you starting to treat them differently in your clinic and starting to think, oh, look, these people don't need exercise, or maybe need less exercise, these people need more, or what was sort of going to maybe the motivation a bit more?
Yeah, I'll start off by saying, it certainly wasn't about treating them different. I'm still standing by exercise therapy as the gold standard, and that's what we should be doing until we have evidence to say otherwise. But the real question that I was starting to ask is, who are the patients? Everyone shares this diagnosis, but over the course of a year, 2 years, I'd seen over 100 people with mid-portion Achilles tendinopathy. And they ranged in age from 18 to 65 years old. They ranged from college athlete to grandparent. Their goals were return to sport to, I just want to be able to walk again with my grandchild. Then the inciting incident, when did this pain come and how, and the histories were so spanning. And I said, there's a lot more under the surface here. Yet everyone's getting this same exercise treatment. And we recognize that, the treatment is individualized, meaning that you can only tolerate a certain amount of load and not everyone's going to have the same weight on the barbell. But I think there's going to need to be some sort of additional treatment or modification to the gold standard in order to get everyone to the same finish line. And so that's what really motivated it. We seem to have the treatment that works for almost everyone. 6 out of 10 people will get better with the standard of care. If you Googled my Achilles hurts and someone finds the treatment protocol on the internet, doesn't matter which one it is, it seems to give a benefit. But for some people, it seems that they can only get so far, or maybe they have a harder time. And so my first question was thinking about, well, do we need more time, or do we need an alternative strategy? But before I could start asking those questions, I needed to know, are there patterns here? Is it really just a random assortment and this is the best we can do? I didn't think so. I thought there has to be a way that we can categorize and start to at least get closer to precision treatment strategies by trying to determine among those patients what makes some very similar yet very different than another cohort within the cohort.
So thinking about that, basically looking at Achilles tendinopathy as a heterogeneous group of patients, which we know that they are, how did you then, so that's great. And then you're sort of thinking, okay, they're heterogeneous, they're really different. We want to understand what are some of the similarities and differences between them. How did you then go on and start to, what was just talk us through the methods, how you guys approach that question?
So I guess the simplest thing is to say we started with what we knew. We have this set of outcome measures to assess patient symptoms. We have a test battery that assesses lower extremity function and the tendon itself in different capacities. We're collecting comorbidity information and anthropometrics. We're collecting demographic information. We're collecting psychosocial factors and determining whether or not someone has fear of re-injury or fear of their pain. And then we are already conducting ultrasound exams and taking measurements of tendon morphology and structural and mechanical properties. So we started there. Okay, well, we already are collecting these things to see how they change over time. Let's take these and see, does everyone have the same characteristics or clinical presentation in each of these domains, or can we pull out certain profiles that people will navigate towards when we look at this through that statistical model?
Yeah. So you've taken all these factors, you've taken a whole bunch of factors, and it's an impressive array of factors that you've taken. And I'm not going to go through them all.
I think there's 14.
14 factors, but
maybe.
Yeah, there's tendon structural, mechanical properties, there's psychological factors, pain-related factors, lower extremity function factors, and symptom factors. Does that pretty much cover them all?
Yes. So those 5 are what we consider the domains of tendon health.
Yeah. So that's yeah. So you've got all those domains. And you've got, multiple measures within some of those domains, which is great. And you've got a real thorough look at sort of some of the factors there. And then how did you just talk us through a little bit more about your methods, how you, it would have taken you a long time to measure all those domains on every single person. You got basically a whole bunch of people in the lab. You put them through all these measures and then you did some fancy stats on them. Tell us about that.
Yeah, so I certainly could not have done this alone. There is a small army behind the Silbernagel lab, and this data collection takes us anywhere from an hour and a half to up to 3 hours to collect all of this data per person. So I guess to start with, the method that we're using is known as mixture modeling. There's a joke that it's almost the art of unscrambling eggs. We have this mixture, but we're trying to determine how many eggs made up the mixture. So the idea is that we create what makes the profile. And so I had these 14 variables that we selected. These are probably meaningful, that seem to have some clinical significance, or they will have in the literature has already been shown to be an important factor in some way to either recovery or to clinical presentation or severity. And so it's an iterative process. I would try it one outcome. If it seemed to improve the model and make things a little bit clearer, we'd keep it. And if it did not change the model, we would remove it. So things like sex, symptom duration, those didn't seem to have much of an impact on determining differences within the cohort. Same with BMI, actually. Those were, I think, the main three that we ended up removing. And so the next question is, all right, well, is everyone scoring all the same on these measures? We'd run this saying, is there 2 distinct groups? Is there 3? Is there 4? And so we rerun this every time and comparing several different models and comparing their fit statistics, we can make a pretty well-informed guess how many groups the stats say there are. And then once we think we're there, there's some statistical, we'll say, rules to follow. Then we sit back and it comes to expert opinion. So no one better than to have Dr. Karin Silbernagel sitting next to you when we want to bring in an expert opinion. We say, does this make sense? And there was a slight, question of, well, it could be 4, it could be 3. The stats are a little bit gray, which, again, just like everything else, clinical practice is gray. It came to it that this 3 subgroup model seems to be the best fit, the most appropriate. It makes clinical sense. And once we would examine the differences among the groups, we said, yeah, this is what we see in clinical practice.
Tell us about those 3 groups in a bit more depth. Can you just describe those groups? What are the key characteristics of each of those groups?
Sure. So I guess we'll start with what we'll say is the typical patient with mid-portion Achilles tendinopathy, which I've come to decide there is no such thing. But when we look at the entire cohort, in this study, I believe I had 145 patients. I hope I'm right. We look at, well, how does the entire cohort perform on all these outcome measures? And then we can compare how that subgroup performed in relationship to what we'd consider the average patient. And so what we first found is comparing the 3, there were this first group that seemed to have the most amount of patients, I think greater than 50% of the population or of the cohort. And they seemed to outperform everyone else in their lower extremity function. They had the least amount of symptoms. They had the best quality of life, the lowest psychosocial factors. Their tendon structure was considerably small, closer to normal, would say, than the rest of the cohort. And so we saw them and we went, all right, that's what we got. Let's look at the other 2. The next largest cohort, we see 3 distinct things and starts to kind of tell a picture. We see deficits in their functional performance. I see, and we saw higher degree of symptoms as reported by their Visa A questionnaire, and their reported pain with single leg hopping. Their quality of life is very poor. And then we see this very profound increase in their self-reported fear of movement as measured by the Tampa scale kinesiophobia. And then we look at their tendon structure and everything is actually very similar to the first group. So we think, okay, if tendon structure governs function, that doesn't seem to be a relationship. Maybe it's actually their symptoms and their fear that is affecting their performance in these functional tests that we're performing. Then we look at their anthropometrics and we see they're actually overweight, near obese. They're about a decade older than the first group. And so we start to realize there seems to be a psychosocial component going on here among maybe some metabolic factors that we haven't explored yet. So we named that first group psychosocial dominant. And then that kind of started to lead the way into how we named the other 2. So the final group was the very small minority group. I think there was 15 patients in this group. And the 2 things that really stuck out with them, the most profound, was their tendon structure. Not only their cross-sectional area and their tendon thickness, but their measures of mechanical properties were the largest of everyone. So much so they almost double. And then when we look at their functional performance, they were almost, if not half, the ability to jump in height and basically their heel rise function and abilities to just complete heel rises. Almost everyone in the group could not complete a single repetition of a calf raise. So we see this massive, clear delineation of dysfunction in this group. Then we look at their symptoms. They're pretty similar to everyone else. They have this general was say moderate to no fear of movement as measured by the outcome measures. Then this group is also the oldest. They're actually a decade older than the other two groups. They're 20 years older than the majority. So we start to kind of put the pieces together. Okay, we look at the previous literature and we say this group seems to be plagued the most by deficits in tendon function and structure. So again, trying to come up with what can be a name that really sticks, and when you hear it, it paints a picture in your mind of this is the person. So we came up with structure dominant. And then again, that informed the very first group. We realized that this is the youngest group. They seem to be the most athletic and performing the highest. They're not really that impaired overall by all of our measures. So we named them activity dominant. And I should say those groups did not just come to us overnight. That was weeks and weeks and on to months of ideas and workshopping, bringing in many different opinions and ideas. And I think actually I want to give some credit to, I think the editor-in-chief, Claire Arden, actually helped us come up with these final names.
Really good, really, really good. What do you make of the association between age and all those groups in terms of, because that's interesting how you're describing it there with age sort of going up between the groups going to psychosocial dominant and then going to structured dominant. What do you make of that association?
I mean, it's difficult to really just pull one piece out like age and speculate on it. But I do think it does kind of lend itself to some assumptions of, okay, as we age, we're talking about here the span of a college athlete, or at least a young adult who is starting their career, is probably having a lot more free time on their hands. And then throughout the normal trajectory of life, the job gets more involved. You maybe start a family. All these different factors come in that might influence your physical activity levels. And so maybe we start to see that might influence why the youngest, most fit group is jumping way higher than the group 10 years older. And then obviously the general aging and things that does to us, right? Trying not to join the older groups myself right now. And then I think the last group, the structure dominant group, we're really seeing there a combination of the level of physical activity is lower. We did capture at least what they should be doing on average in a week. And we see the obesity is a factor. We were unable to attain anything further about metabolic factors, but I think those, combining their age and their abilities to really start a physically active protocol like we're asking them to do. Maybe we're asking them to start a wellness program and maybe some weight loss focus as well. It's a lot harder when you're in your 60s, I would assume. I'm not there yet, can't say, but I think the age certainly seems to have a factor, but I don't think it's a single driving force. I think there's a lot more to it.
Yeah, it's interesting how you put it that way, and I think that's a good perspective. There's a lot of interaction potentially between all these different variables as people age. There's other things that are going on, physical activities changing, and perhaps some of their thinking and beliefs are changing. Perhaps they've had their tendon problem for a longer period of time. Did you find that with some of the groups? Was time of pain a factor or not really?
No, actually, that was one factor, that there was no significant difference among the subgroups in that. And the range there, we have a very wide range in our cohort between 3 weeks and over 10 years. And wow. So with that, it doesn't get much wider, I think. So much to my surprise, and that's something that we are currently exploring. But it doesn't seem to be any informative variable to have symptom duration and have any effect on who these patients are and what subgroup they might fall into.
Yeah, look, it's really interesting. And I think the good thing about this study is that there are so many hypotheses and questions that come out of it. So what drives this psychosocial dominant group to be a little bit less functional? Is it fear? Is it the BMI, is it age, is it change in strength, there's all these things. And there's so many questions that arise from it, and same with the structure dominant. But did you look at, I guess you weren't powered to do this, and you probably haven't, because you're a good PhD student and you wouldn't go down that path. But did you look at some of the interrelationships between those variables? So say, for example, the psychosocial dominant group, there's 56 people in there. Did you say, okay, does actually their psychological function predict their strength?
No, I did not tamper with that. That's a slippery slope. And again, in the interest of not only being a good PhD student, but being a PhD student, I had to make sure I stay on track and finish in a timely manner. As you said, the number of questions that came out of this paper for me could fill up 3 notebooks. So it's hard to really choose where we go from here.
Well, I think it's a really, really good starting point to then explore some of these different relationships and even try and replicate this in future. But let's move on to some of the a couple of the last questions that I want to go through on this paper. Just tell us now about what are your thoughts on how do these different groups behave? And I know you've done some work on this. How are you finding that with your longitudinal work, which I know isn't published? But can you give us a bit of a preview on, what is the actual importance of these groups in terms of, if we just, look at how they behave over time?
Yeah. So again, without spoiling too much, we were able to watch this group and compare their changes over time across 6 months. And so what we ended up trying to do is, in the interest of, okay, not everyone is impacted equally by Achilles tendinopathy, we probably shouldn't be measuring recovery the same way for all groups. So one of the things that we strove to do was separate recovery within the domains that we are talking about. So we assessed symptomatic recovery separate from functional recovery, also including structural recovery, and then psychosocial recovery. And so again, just using the same factors the same outcome measures that we mentioned that name the groups, we wanted to compare behavior over time. If we give everyone the same treatment, does everyone respond the same, or do they recover differently? And so without giving too much away, I bet everyone could probably even take a guess. The activity dominant group, because they started off minimally impacted other than symptoms, that was our big concern for them, is how does symptoms recover over time? I don't expect them to all of a sudden at 16 weeks have a big dive in their heel rise workability. And so what we ended up seeing is that function remained just the same with the activity dominant group. They didn't really seem to have any improvements. But again, I don't really think they ever had any deficits to begin with. And we captured that by comparing limb symmetry indices between them, and then also looking at the most symptomatic limb and its performance in jump height and total heel rise work and ability every 8 weeks. As far as symptoms go, this is actually probably one of the most important things, I think, to drive home. At 6 months, every single group still had considerable symptoms. So it seems that one of my big things is that we're trying to say recovery takes longer than what we think. And so to the clinicians listening, I think one of the big messages I'm trying to drive is don't get discouraged when the 12 weeks run out and your patient is still having symptoms. They haven't returned to the level of function that you expected. It's okay. It seems that there's more to be gained if we continue the process. Even if they're discharged from your care, as long as they stay the course and continue to modify their activities, it seems to be okay. That will continue to improve. As far as the structural recovery, we saw big differences. Again, saying the activity dominant group didn't really have a big difference or a big change in their tendons to begin. The psychosocial group, again, same thing, didn't have a big tendon or a lot of change to be had. So both those groups didn't really have much structural recovery to concern themselves with. But the big interesting thing is that the structural group, they did actually have a significant reduction in their tendon thickening over the course of the 6 months. And so while they're still not recovered by the means of, if they were in the clinic and you're asking how you feeling and, you know, are you able to return to run yet? They're not. But healing is happening. So that was probably one of the big takeaways that I think, you know, knowing who the groups are, we see that there's some interesting things if we start to really piece apart what is recovery. The subgroups do matter when it comes to what we're measuring and why. And then finally, the psychosocial aspects. It's really tough to say because our treatment is considered comprehensive. We are not just giving them the exercises to complete, but we are also asking them to follow a training diary. So they're asking them to monitor their activity and their symptoms on a regular basis. And we are asking them to follow the pain monitoring model, which again assesses their, protects them rather from pursuing activities that are, you know, high risk or really irritable to the tendon. And so in that, it's a bit of a pain education. So it's really hard to say, was it the exercise or the pain education? But the spoiler alert, I guess, is that it does seem to be effective in reducing fear of movement for everyone. If you had some to begin with.
When just to clarify that point, do you mean that all the groups, all the subgroups had a reduction in pain-related fear?
Correct. So by the end, nearly every group had recovered to what we consider a low level of fear of movement.
That's interesting. But I imagine the group that had the highest levels to start with had the most improvement in that?
Yes, but again, they had the most to be gained. But if I remember correctly, pretty early on, we see a pretty steep reduction in fear. And again, there's a number of things that could have alluded or, you know, created that reduction.
Yeah,
I could just say we just have really good PhD students who know how to tackle fear of movement.
Yeah, it's an interesting one because, as you say, you've done a comprehensive treatment. You've covered a lot of elements, and lots of stuff has improved. I guess the question to ask then, follow on from that, is what sort of things did you see not improving, or what sort of, you know, particular things from some of these subgroups might you be targeting in a different way? Have you given that any thought?
Yeah. So I think the overall, and again, I don't think I'm giving anything away to say, you know, anyone who is an experienced clinician would recognize who these subgroups are and would kind of know there will be additional considerations for those who would be psychosocial dominant or structural dominant. And I think where we're heading is this idea that the psychosocial dominant, for all subgroups, exercise therapy is the first line of care, and that will not change. But I wonder, will the psychosocial dominant benefit from exercise therapy plus some form of pain neuroscience education, some form of guided, you know, graded exposure to getting them to do the exercises? We haven't really looked into the implementation considerations of were they any less compliant with their home exercises? You know, what else could have maybe created this divergence in recovery? But at the 6 month mark, we're still seeing deficits in function in two subgroups, and the activity dominant seem to have recovered their symptoms and function. So it seems to be that maybe those are the two that I'm targeting first. And so again, for that structural dominant group, we have to zoom out and remember who our patient is. We still have a potential confounder with their body mass, with their physical activity levels. So maybe for that structure dominant group, there's an additional level of getting coaching in there that would help with increasing their physical activity levels, creating a better lifestyle. Maybe it's nutrition. And then I think from there, that's kind of where my jumping off point will be. But the next thing I think is really that's my next dive, is to really look back into, I started off with, do they recover differently? My next move is why. Why do they not recover the same?
Yeah, I think that's a really good logical next step, to have a look at that. And as you say, there might be physical activity interventions, there might be other ways that we can treat them with exercise, or there might be also other education strategies we can do for some of these groups. As you say, there's two groups that are still not recovering as quickly as the other group, or it could be just time, as you mentioned earlier.
And I really think that is something that, it's a challenging thing in clinical research to keep, a trial going for beyond a year. But I think that's where some of the mystery lies is, have we just not had a study that runs long enough to see appreciable change in the structure dominant group, for example, the ones that might have a metabolic component that's impeding their tendon healing, and the other, lifestyle related changes that maybe are also hindering their abilities to hit the same pace that the younger, more physically fit or more, I guess, just those factors.
Yeah, I think, as you mentioned there, the adherence aspect. So is it also related to, somehow to adherence and what people are actually doing and how they're sticking to the treatment? So look, lots of things to explore, so many things to unpack, and that's why it's a really interesting study. So once again, I'd recommend everyone reads it. Just the last question then, to finish off, what would be based on all your work, and not only this paper, but your clinical work, and your sort of obvious interest in the area of Achilles tendinopathy, what are your top tips for clinicians to finish off in treating Achilles tendinopathy?
Oh, my top tips for clinicians.
Yeah, and you can't say just go and read the paper.
Fine. I think the top tip is know who your patient is. Part of the goals of this paper was to give a clinician the tools to identify who their patient is in these subgroups. So there is a classification model in there. I do think it does a pretty good job of delineating who your patient might be. But again, if you're only asking the age-old questions of how bad does it hurt, when does it hurt, what do you want to get back to, that's only one very small piece of this puzzle. If you're not looking at or investigating, is there a component of fear of movement? Are they afraid of rupturing their tendon? What is their lifestyle like? I think that's really it. This is a complex injury, and it takes a comprehensive examination to really turn over every stone and make sure you have a complete clinical picture before you immediately go to the protocol sitting in your desk that reads Achilles tendinopathy on the top.
Yeah, that's fantastic. That's really good. That's a good answer. And it's sort of, and that's another reason I like the study. It sort of focuses people on a biopsychosocial approach and just looking broadly at all the factors that can contribute to disease and, prolonged symptoms and dysfunction in these patient groups that we treat, which can be, very heterogeneous. So that's great, Shawn. Look, I really, really appreciate you coming on. Thank you very much for that. Look forward to seeing all the work that comes out over the next few years to try and unpack some of these questions that we've raised today. Thanks very much.
Thank you so much, Peter. This has been a privilege.